The following podcast is part of a certified educational activity titled Planting Roots for Next-Gen Bispecific Antibodies in Hematologic Cancers. Collaborative Principles to Extend the Reach of Immunotherapy in Myeloma and Lymphoma. Access the entire activity and complete the post-test at peerview.com/PJA860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Hans Lee from MD Anderson Cancer Center. I'm pleased to be joined by my colleague, Dr. Jeff Fiorio from Texas Oncology. Today, we're going to explore the emergence of bispecific T-cell antibody-based treatment in hematologic malignancies, focusing on how community and academic hematology oncologists can collaborate on delivering the best possible care with these unique off-the-shelf immunotherapies. Throughout the program, we'll review evidence and guidelines supporting the use of established and emerging bispecific T-cell antibodies, but also provide insights on how to safely administer these agents in outpatient and inpatient settings. Let's begin. So we have several goals for today. Our first goal is to improve your understanding of evidence and guidelines supporting the use of established and emerging bispecific T-cell antibodies in hematologic malignancies. We also hope to help you develop collaborative protocols for integrating bispecific T-cell antibodies into the sequential treatment of diffuse large B-cell lymphoma, follicular lymphoma, and relapsed refractory multiple myeloma, and finally provide you with guidance on how to address therapy delivery considerations with bispecific T-cell antibodies. So in the first part of the program, we'll discuss some of the data on the mechanism of action and the current role of bispecific T-cell antibodies for multiple myeloma and non-Hodgkin's lymphoma. So first, I want to start with this slide, and this really highlights the purpose and the premise of this program. And as many of you know, bispecific T-cell antibodies for multiple myeloma and non-Hodgkin's lymphoma has really emerged as an important modality of therapy for patients with non-Hodgkin's lymphoma and relapsed refractory multiple myeloma that can be delivered both in the academic setting, but also in the community setting as well in off-the-shelf format. In a recent poll, though, that we conducted among hematology oncology clinicians in the community settings, and this included over 100 participants who responded to the survey, over 60% of practitioners noted limited experience with bispecific T-cell antibodies in hematologic cancer settings. So our goal is really to hopefully improve your comfort level in potentially administering these agents in your practices. So as many of you may know, bispecific T-cell antibodies are basically two-armed antibodies, where one arm of the antibody binds to CD3 on the T-cell receptor, and the other arm of the antibody binds to a tumor-associated antigen such as CD20 on B cells and BCMA or GP or C5d on the plasma cells. And I think what really makes bispecific T-cell antibodies a unique modality of a T-cell redirecting therapy is that unlike CAR T therapies, which require apheresis and manufacturing of cells, bispecific T-cell antibodies are really administered as a conventional drug off the shelf. And so to date, there's been several bispecific T-cell antibodies approved for the treatment of relapsed refractory multiple myeloma, including two that target BCMA, including teclistamab and elranatamab, and taquitamab, which targets a different tumor antigen, GP or C5d. And I did want to mention that there's a third BCMA bispecific T-cell antibody, linvoseltamab, that's currently under review by the FDA for potential approval for later in 2025. That's already also been approved in Europe by the EMA for patients with relapsed refractory multiple myeloma with at least 3 prior lines of therapy. In addition, there are several bispecific T-cell antibodies approved for the treatment of non-Hodgkin's lymphoma, including mosunetuzumab, which is approved for the treatment of follicular lymphoma, epcoritamab, which is approved for the treatment of follicular lymphoma as well, and glofitamab, which is approved for the treatment of diffuse large B-cell lymphoma. In addition, odronextamab is an investigational bispecific T-cell antibody that targets CD20 that's under investigational use in the United States and approved for the treatment of relapsed refractory diffuse large B-cell lymphoma and follicular lymphoma in Europe. So This slide is really straight from the NCCN guidelines, and currently, BCMA bispecific antibodies in multiple myeloma, elranatamab, talquetamab, and teclistamab are approved for the treatment of relapsed refractory multiple myeloma with at least 4 prior lines of therapy who are triple class exposed. This means that patients are exposed to a CD38 monoclonal antibody, a PERS inhibitor, and an immunomodulatory drug. This slide here summarizes the data from the pivotal trials that led to the FDA approval of teclistamab, elranatamab, and talquetamab. As you can see here, the overall response rates are quite unprecedented for an off-the-shelf agent for heavily pretreated relapsed refractory multiple myeloma with overall response rates of 60 to 70%. Not only did patients have a high rate of response, but the depth of response was quite encouraging, with the majority of patients attaining a very good partial response or complete response or better. And finally, the overall response rates not only were high, but the durability responses were also very encouraging, with median progression-free survival of over 11 months with teclistamab, over 17 months with elranatamab, and 8 months with talquetamab, which arguably was a more heavily pretreated patient population than either teclistamab or elranatamab in their pivotal studies. So there are sort of some nuances in how these agents are delivered. And pretty universal across the 3 FDA-approved bispecific antibodies is this concept of step-up dosing. And so, for instance, with teclistamab, this is a subcutaneous bispecific antibody that targets BCMA. Patients receive an initial very small priming dose of the drug, 0.06 milligrams per kilogram on day number 1, and then step-up dose number 2, intermediate dose on day number 4, and the first treatment dose on day number 7. And the step-up dosing strategy is really incorporated to mitigate the risk of cytokine release syndrome and potentially neurologic toxicity as well. And so as per the package insert of teclistamab, it's recommended that patients should be hospitalized for 40 hours after each of the initial step-up dosing for CRS monitoring, so essentially after days 1, 4, and 7. I did also want to mention that the package insert does offer some flexibility in the timing of the step-up dosing. For instance, step-up dose number 2 can been given plus or minus one day of day number 4, and the first treatment dose or step-up dose number 3 can be given plus or minus 2 days from day number 7. So there can be different dosing strategies utilized. For instance, some centers incorporate a more of an accelerated step-up dosing on days 1, 3, and 5 using these treatment windows for the step-up doses. And then teclistamab is administered weekly initially, and then per the package insert, patients can be de-escalated to every other week dosing of attaining a complete response or better for at least 6 months. I do want to mention that there's probably a lot of different strategies of dosing teclistamab in terms of the frequency, and so in generally speaking for bispecific antibodies in multiple myeloma at least, there's a lot of off-label de-escalation, the frequency of dosing based on how the patients respond to therapy. So oftentimes patients do end up getting de-escalated in terms of the frequency of dosing much earlier than attaining a CR or better for 6 months or longer. For elranatamab, it's very similar as well. So patients also have step-up dosing incorporated with initial dosing, so a very small dose, 12 milligrams on day number 1. On day number 4, intermediate dose, 32 milligrams. On day number 8 is the first treatment dose of 76 milligrams. Again, there is some hospitalization required as per the package insert, although a little bit less than teclistamab. So after the first initial step-up dosing, a 40-hour hospitalization is recommended after dose number 1. And then after dose number 2 or day number 4, a 24-hour hospitalization is required. But thereafter, there's no required or recommended hospitalization starting on the first treatment dose and thereafter. And elranatamab is administered weekly initially, and as per the package insert, can be de-escalated to every other week, starting week 25, if a patient attains a partial response or better for at least 2 months. Although in practice, like teclistamab, there's often off-label decrease in the frequency of dosing once a patient does attain a response to therapy. And then finally, with talquetamab, this also incorporates step-up dosing, as you can see here on this slide. And depending on whether a 0.4 mg per kg weekly dosing or 0.8 mg per kg every other week dosing is chosen in the end, there can be either 3 or 4 step-up doses incorporated in the initial step-up dosing schedule. And then, like teclistamab, a patient should be hospitalized as per the package insert for 40 hours during the initial 3 to 4 step-up doses. So I did want to try to change gears and talk a little bit about some of the investigational bispecific antibodies in relapse refractory multiple myeloma. So linvoseltamab, as I mentioned earlier, is currently under FDA review for potential approval later in 2025 for the treatment of relapse refractory multiple myeloma, and was recently actually in the last month approved in Europe for the treatment of relapse refractory multiple myeloma for at least 3 prior lines of therapy. You can see the structure of linvoseltamab here. Again, it targets BCMA on one arm of the antibody and CD3 on the T-cell receptor. And when the T-cell antibody engages both the myeloma cell and the T-cell, at least the T-cell mediated death of the myeloma cell. And so the submission to the FDA for review of approval for relapsed refractory multiple myeloma was based on the pivotal linker MM1 study. So this was a phase 1, phase 2 study that enrolled heavily pretreated relapsed refractory multiple myeloma patients. And the results were very, very encouraging with over a response rate of 71%, with the majority of patients attaining a complete response or better, over 50%. I think what was also very encouraging about these results was that the responses seem to be durable, with the median duration response of 29 months, and the median progression field not reached actually at a median follow-up of over 21 months. Something else to note about linvoseltamab is that in subgroup analysis, there did also seem to be very encouraging responses and historically very difficult subgroups of multiple myeloma patients to treat, including patients with pentarefractory disease, patients with high bone marrow postocytosis, more than 50%, and patients with high soluble BCMA levels in the blood. This is the dosing schedule of linvoseltamab, and so like the other bispecific antibodies that I've already discussed, there is step-up dosing incorporated. So there is initial 5 milligram dose on day number 1, 25 milligram dose on day number 8, and the first target dose on day number 15. And so they're a little bit more spread out than the other BCMA bispecific antibodies. So again, spread out by a week. And then there's only a 24-hour hospitalization after the initial first 2 step-up dosing. So only 40 hours total hospitalization during the initial step-up dosing period. And so this is in part because linvoseltamab is given intravenously, and so there can be advantages and disadvantages of intravenous versus subcutaneous bispecific antibodies. So subcutaneous bispecific antibodies are probably advantageous because you don't have to have an IV line placed to administer the drug. On the other hand, intravenous bispecific antibodies tend to have a little bit more of a predictable cytokine release syndrome onset and resolution pattern. So the median time to onset of CR is about 24 hours, and the median time to resolution is about 24 hours or so. So again, this is more quick, generally speaking, than subcutaneous formulations, and hence the shorter inpatient hospitalization that's required when administering these agents. Something else notable about linvoseltamab is that there is a prospective rapid de-escalation of the frequency of dosing incorporated in the protocol. So patients receive weekly dosing initially for weeks 3 through 13, then every other week dosing for weeks 14 through 23. And then patients could then de-escalate to every 4 weeks in a response adapted approach if attaining a very good partial response or better. Finally, I want to talk about another emerging BCMA bispecific antibody, entectinib, otherwise or previously known as ABBV-383. And so this is also being studied in phase 1, phase 2, and phase 3 clinical trials. You can see the structural entectinib here on the slide. So unlike the other BCMA bispecific antibodies, it actually has 2 BCMA binding domains. It also has a low affinity CD3 binding domain, which at least preclinically seemed to decouple T-cell activation and cytokine release, which had some impact on the dosing schedule, which I'll get into in the next slide. And so entectinib actually has a slightly different dosing schedule. So unlike the other BCMA bispecific antibodies, actually entectinib doesn't actually incorporate step-up dosing. So actually patients get the initial target dose right away, in part because potentially they attenuated CD3 on the bispecific antibody. And patients also actually get the dosing quite spread out initially. So the recommended dose moving forward is every 4-week dosing. So patients, again, get the target dose on day number 1 every 4 weeks, so quite infrequent these and spread out, starting with initial dosing. And there's only a 24-hour hospitalization required after the initial infusion of entectinib. So there's a lot of sort of considerations in how we sequence myeloma therapies in general. I think one of the great things about multiple myeloma in 2025 is that we have lots of therapeutic options, both non-T-cell redirecting options and also T-cell redirecting therapies such as bispecific antibodies and CAR T therapies. And so while there are lots of options, one challenge is actually how do we optimally sequence these agents? And I think there's a lot of considerations that come into play. And so, I think, this is a question that we all face, Jeff, in our practices, and just curious of how, your approach is when you see a relapsed refractory multiple myeloma patient, choosing between referring for CAR T versus bispecific antibody. What are some of your thoughts on that?
Yeah, I think it's become more difficult as we have these newer therapies available, and what's the right thing to do or right sequencing. So I think up to now I've sort of thought about health of the patient, kind of performance status, and sort of thinking about kind of CAR T viability. I'd say are they able to handle going through a CAR T type of treatment versus not. And so that's probably been my leaning of if I think that they're somebody who could go through CAR T-cell, then trying to get them, referred or going through a CAR T treatment first. Whereas if they're a little more borderline, would have a harder time, let's say, staying close to like a center where they're going to have CAR T-cell, have to do the CAR T-cell and be close to that center, then maybe doing something more like a bispecific instead. But I don't know if there's a right or wrong method there.
Yeah, no, I completely agree. I mean, I think, there's so many variables involved and every patient is, different. And so this is where sort of the individualizing the therapy comes into play. And I kind of was struck by something you had mentioned about, if a patient can travel to a CAR T center, right? And I think that's a big limitation with CAR T in general. I think they're highly effective therapy overall, but I think in terms of how do we improve access to our best therapies for our multiple myeloma patients, having something off the shelf potentially could be advantageous in certain contexts. So you can see here, like on the slide, there's multiple different sequencing strategies that we can employ. So sometimes, as Jeff, you had mentioned, if a patient gets a CAR T first initially on the blue here, on the blue boxes, then they potentially get a bispecific antibody that targets BCMA or GP or C5d. Subsequently, there can be a reverse sequence where patients get a T-cell redirecting therapy initially, then a BCMA CAR T later on. And there can also be sequencing of bispecifics, right? Sometimes patients get a BCMA targeted bispecific like talquetamab or teclistamab, and then subsequently get a GP or C5d targeting bispecific like talquetamab, subsequently, or even vice versa as well. And so I think lots of different factors that can come into play, if a patient can potentially travel to a CAR T, what the referral patterns are. I think one of the challenges is a patient has really, really rapidly progressing disease. It may be hard to get a patient to CAR T just because they need treatment right away. So perhaps that's where an off-the-shelf approach with a bispecific antibody might be helpful to get treatment done right away. And so I guess another question is, do you get a sense of sort of like, in terms of when you talk about these therapies with patients, do they have particular preferences, or do they sort of have sort of background in which potential therapies they might prefer, just out of curiosity?
Yeah, I mean, I think some people do. I mean, they come in, either one, they've heard about CAR T-cell, probably more so they've heard about CAR T-cell, I feel like. Although some are pretty savvy and have read about and heard about bispecifics. And so I think some of them are very drawn to CAR T because, yes, it's an intensive treatment, but then the idea of not having to be on any treatment for a while is pretty, pretty appealing to these multiple myeloma patients who've been on something probably for a really long time. So I think there's that appeal for a lot of patients that when they come in and you kind of talk about the differences. And then like you just talked about some of the other side of it of just travel and, having to deal maybe more with like being in a hospital maybe for a longer period of time or those type of things, maybe with CAR T that a few patients might lean the other direction. But and then of course there's patients that they're walking in blind and don't really have a preference whatsoever, and you're having to kind of guide them through that treatment. in your experience, have you had kind of a lot of people with preferences one way or the other, or leanings towards CAR
Yeah,
T
I think
over?
it's very similar. I mean, some patients know exactly what they want, and they essentially say, "I want, a CAR T or bispecific." Some patients don't know really much about these therapies, and so a lot of it is our sort of jobs to educate patients on the different options. But I think due to different reasons, different preferences, patients may prefer the initial upfront intensity of a CAR T, but then potentially have time off therapy on the back end. On the other hand, some patients, can't afford to take that time off to undergo a CAR T therapy and then prefer to do a bispecific antibody just because it's more feasible with their personal lives, and so they don't have to interrupt, things as much, or rely on as much on a caregiver.
What's your experience using kind of CAR T post bispecifics? I think probably a little less of the true data out there a lot of times, just since CAR T kind of came along a little bit first.
Yeah, that's a great question. You're absolutely right. We don't have much data on sort of the sequence of doing CAR T after bispecific, and there's a little bit of data from the CAR T to cohort C, which showed sort of inferior overall response rates and durable responses administering cilta-cel after T-cell redirecting therapies. And so I think just because now CAR T therapies are approved in earlier lines compared to bispecifics, we probably will see more data on bispecifics after CAR Ts. But when T-cell antibodies get approved in earlier lines, as anticipated maybe in the coming years, we'll probably have more real-world experience on that sequence that you just mentioned. So I wanted to hop over and talk about a few cases here. And so we have Jane, who's a 78-year-old woman with triple-class refractory multiple myeloma. So this is a patient whose disease is refractory to IMiDs, PRRS inhibitors, and CD30 monoclonal antibodies. The patient has renal dysfunction, has high-risk disease with 1q21 amplification and deletion 17p, and is also pretty frail, has a performance status of 2. And the patient receives frontline RVD, auto transplant, len maintenance, second line Darapom Dex, third line carfilzomib, cyclophosphamide, dexamethasone, and fourth line selinexor, pomalidomide, and dexamethasone. With really shorter duration of response with each sequential line of therapy. And so this is a patient that I think we've all probably seen in our clinics at one point or another. And I guess what would be some of your considerations in this patient of, CAR T versus bispecifics, and seeing a patient like this?
Yeah, she's 78, and then obviously has a really kind of a nasty myeloma type disease just with her cytogenetics, and clearly she's quickly kind of blowing through her most recent treatments. So the pace of her disease and resistance is pretty impressive. And so she's probably one where I'd lean more towards the bispecifics, I think, just because getting her to CAR T and going through that whole process might take a little bit too much time, I feel like. And so that'd be one where maybe I'd lean a little bit more towards bispecifics as an option for her.
Yeah, I mean, I think this is a challenge, like which one to do. I think if a patient may have a good bridging option, which in this particular case, the patient has seen many lines of therapy already, is refractory to pretty much all the standard myeloma drugs, it can make getting to CAR T more difficult, particularly if this patient has a rapidly progressing disease. And so, perhaps this is where a bispecific may make more sense. Does the performance status of 2 sort of impact you at all in terms of CAR T versus bispecific?
I mean, I think it probably makes me lean a little more towards the bispecifics. Not to say it would totally exclude her, I think, from CAR T, but probably lean a little bit more towards bispecifics as being able to tolerate that.
And then like GPRC5D versus BCMA, there's some thought like, why do we always do BCMA before GPRC5D? It comes first in the alphabet, so maybe B before G. But But do you have any like thoughts on how you choose between, you know, teclistamab, ransomab versus talquetamab? Like,
Um,
what's your kind of thought process
yeah,
there?
no, I mean, I think I don't necessarily have a preference. As you said, I think probably we've maybe used the BCMA ones first most of the time, but I don't necessarily have a good preference one or the other. I think some of it's logistical considerations and I don't think I've had any issues myself so far. And I don't know if you have with, insurance considerations or, who maybe preferences of certain insurances, but I'm sure that could also be an issue that people have to think about as far as if there's a preferred agent uh, that the payer might have. But
Yeah, and I would say that we'll talk a little bit more about. Sometimes I'm um, uh, uh, swayed by sort of the toxicity profiles potentially. So if a patient has history of lots of infections in the past, I think generally speaking, BCMA bispecific perhaps have a long-term higher infection risk than GP or C5d targeted therapies. On the other hand, there's a well-known toxicity profile of talquetamab, the on-target off-tumor adverse events with a dysgeusia and skin and nail changes. And so I think, these are all potential factors of choosing one agent versus another. And then this, same patient. So let's say hypothetically, you choose teclistamab or ransomab, one of the FDA approved BCMA bispecific antibodies. What's your sort of like workflow and getting the patient actually on the therapy?
yeah, I think initially when we started to use these, we were working certainly with either big academic center or kind of our transplant nearby transplant team to sort of enact this type of treatment. Now we've kind of expanded that out a little bit more to start to kind of have a group of physicians within our practice that work and help with kind of step up dosing and try to collaborate with them to get this therapy enacted. The challenge we've had in the community has been where do you receive the drug and where do you monitor them at, and sometimes because of the payer situation, it can be pretty hard to just administer it in the hospital setting itself. So a lot of times we're actually administering it in our clinic and then admitting or getting the patient to be monitored, right afterwards in an observation type of setting in the hospital. And so there's been that coordination to make that happen, which takes a little bit of, between both the inpatient infusion room and the outpatient, inpatient kind of setting and the nursing staff there, then the outpatient infusion room and making sure we have that as seamlessly as we can to transition.
Yeah, that's an interesting point you make. So, potentially giving the dose outpatient, so then the hospital is not actually administering the drug. Is that what you're saying, Jeff?
Correct. So basically having to administer the actual drug itself in an outpatient setting and then doing the monitoring in the inpatient setting afterwards. And again, that's been sort of the truth of just having to deal with how payers are going to actually pay for it. So I think a lot of hospitals are skittish about giving the drugs in the inpatient setting itself because they're worried about reimbursement for that hospital stay and how that looks. And so so that's sort of the compromise we've had to get to with is, really administering kind of in an outpatient infusion room and then that's close by, and then getting them to the inpatient setting to monitor.
But yeah, so I wanted to switch gears a little bit and talk a little bit about some of the evidence supporting the use of bispecific antibodies in non-Hodgkin's lymphoma. And so I mentioned earlier, there are 2 bispecific antibodies approved for the treatment of large B-cell lymphoma, glofitamab in combination with GemOx. For second-line large B-cell lymphoma, epcoritamab and glofitamab approved for third-line large B-cell lymphoma. And then also for follicular lymphoma, there's epcoritamab and mosunetuzumab approved for the treatment of relapse refractory follicular lymphoma. And the approvals of epcoritamab, glofitamab, mosunetuzumab were largely based on pivotal studies that showed very, very encouraging overall response rates, and slightly different based on histology. So over response rates of 30 to 40% with large B-cell lymphoma, over response rates of 60 to 70% with follicular lymphoma. And the durability responses were encouraging, particularly follicular lymphoma PFS ranging from 15 to 20 months or so, large B-cell lymphoma PFS ranging from 4 to 5 months or so. And I did want to mention data with odronextamab, which again is under investigational use in the United States, with really nice data in large B-cell lymphoma and follicular lymphoma, again showing response rates about 30% in large B-cell lymphoma, 73% in follicular lymphoma, with also encouraging durability response as well, as you can see on the slide here. So just briefly to kind of go over the step-up dosing that's incorporated with these agents, mosunetuzumab, which is approved for the treatment of relapsed follicular lymphoma, interestingly does not incorporate any step-up dosing, any inpatient hospitalization as part of the step-up dosing. So patients receive initial 1 milligram dose on day number 1, 2 milligram dose on day number 8, and the target dose on day 15. So again, this is all administered outpatient without any required inpatient observation, which is nice. And then patients also receive fixed duration therapy through cycle 17, and the actual dose is de-escalated 30 milligrams starting on cycle number 3. And then glofitamab, you can see here the dosing. So patients get a dose of obinutuzumab on day number 1, and the initial step-up dosing at 2.5 milligrams on day number 8 of cycle number 1. And patients do have a very short hospitalization that's required for 24 hours after the initial step-up dosing, but after that, everything is given outpatient thereafter with no hospital observation. And then patients then get the target dose starting cycle number 2 for fixed duration for 12 cycles total at 30 milligrams. And then epcoritamab is approved for the treatment of large B-cell lymphoma and follicular lymphoma. You can see here that the step-up dosing differs depending on the histology. For large B-cell lymphoma, patients should be hospitalized after the first full dose on day number 15 for 48 milligrams. For follicular lymphoma, there's actually no hospitalization required for the initial step-up dosing. And then I did want to mention how the step-up dosing is done for odronextamab. So again, this is under investigational evaluation here in the United States. This is approved in the EMA. And you can see here that there's also step-up dosing incorporated on days 1, 2, 8, 9, 15, and 16 with escalating doses. And again, depending on histology, the target dose differs either 320 milligrams or 160 milligrams, depending on if a patient has large B-cell lymphoma or follicular lymphoma. So want to kind of change gears a little bit to talk about potential, real case here. And so this is, 68-year-old gentleman, William, with diffuse large B-cell lymphoma and OS treated with pola-R-CHP and achieves a complete response confirmed by PET-CT. He has an ECOG performance of 1. And 6 months post-treatment, the patient has signs of relapse referred to CAR-T and achieves a remission. But unfortunately, after 6 months of receiving CAR-T therapy, is found to have progression of disease. So basically is going to start third-line therapy. And the question is this patient a candidate for a bispecific antibody or any other therapy that you might consider? I want to turn it back to you, Jeff. What are your thoughts on this patient?
Yeah, I mean, it's unfortunately it seems like a pretty, refractory disease without how quickly he's progressing, through these different therapies. But certainly I think bispecifics would be, a next option for him. So it would certainly go that direction for him.
And then, we talked a little bit about the different approved agents for large B-cell lymphoma, glofitamab, epcoritamab, and they have slight differences in step-up dosing, but also similarities. I guess with large B-cell lymphoma histology, there's going to be a 24-hour hospitalization either on day 8 or day 15, depending on the drug. How does that factor into choice of drug that you would consider in this context?
I think just factoring in, again, what the patient's able to do as far as traveling and things like that. But, with like glofitamab, having to do, I think in the bispecifics for diffuse large B-cell, a little nicer that perhaps we're only having to do the one-time hospitalization. So it's makes it a little simpler, I think, in that respect. So to kind of choose to go that path, but because it's a little less intensive as far as how often they need to actually get hospitalized to be monitored.
I agree.
As well.
Yeah, I agree. I think there's a lot we can learn in myeloma from the lymphoma way of administering bispecific antibodies, of keeping patients out of the hospital and doing this more as an outpatient setting. And so, I guess, and then for follicular lymphoma, I guess mosunetuzumab, you're doing this completely as an outpatient. Is that correct?
Yeah, you could do it completely as an outpatient, which is really for us in the community setting, I think really appealing, so that we're not having to deal with those hospitalizations and whatnot. And so I think from our perspective is just having a good amount of patient education as well involved in that, on things to still look out for at home, and having a good way to communicate with our clinic, even after hours, to make sure that if they're having any changes or anything significant, that they let us know right away. And we've had to do things like just, make sure people that are in our call group or things like that are really attuned to the fact that these therapies are getting administered. And so that, if you've got that really all of our doctors are enough familiar with it to be able to guide patients.
All right. So, sort of in the last part of this program, I want to talk a little bit more about operationalizing the administration of bispecific antibodies for patients with multiple myeloma and non-Hodgkin's lymphoma, and just to kind of talk about some of the main potential toxicities that one might expect. And so I think the most common side effect that one may see is cytokine release syndrome. So this is very common, particularly in the initial step-up dosing of the administration of these agents. So CRS is common, but high-grade CRS is pretty rare. So grade 3 and grade 4 CRS is exceedingly rare. Most CRS is grade 1, some grade 2 CRS, and rarely grade 3 and grade 4. So grade 1 CRS is essentially just a fever. Something else to watch out for is that patients can potentially experience infections, particularly with BCMA targeted bispecific antibodies. And so 35 to 50% grade 3 or grade 4 infection rate with these agents. We'll talk a little bit more about supportive care with infections later on. And then there's this unique sort of on-target off-tumor adverse event with GP or C5d targeting bispecific antibodies, the skin, nail, oral toxicities that one can see that can also lead to weight loss. I will mention that, generally speaking, CRS after the initial step of dosing is exceedingly rare. So is neurologic toxicity. And so there's really no driving restrictions for patients who are feeling well, especially after the initial step-up dosing. There's no need for ongoing neurologic monitoring after initial step-up dosing for our patients receiving these agents. And so kind of want to pick your brain a little bit here, Jeff, on this slide. And so, you had mentioned sort of, operationalizing bispecific antibodies and different models that you guys have explored in your own personal practice of ways to administer these agents in the most safest way possible. So I guess maybe talk us through a little bit about your approach and sort of how you decide to do it in-house, refer out, et cetera, et cetera.
Yeah, sure. So, as you said, finding one patient and kind of talking through the medicine with them and what that means. I think for most of the drugs, outside a few of those, there's going to be some inpatient component. So you're having to kind of talk through that with them. And as I said, in our kind of region, we've tried to either done, at an academic center that's a little far away, or one of our two bigger hospitals that are in our region that have the capabilities to deal with the monitoring and everything. And so just trying to set up that kind of education with the patient and making sure they have a caregiver that can be involved. So that's another big thing when you're giving these bispecifics. If they're going to be going from an outpatient to inpatient setting, they need a caregiver that can be involved and attuned to what's going on. And kind of talk through with what are those immediate toxicities kind of even laying those out for them and talking about, monitoring for the fever. I think a lot of them, especially up front here, we've even, if they're able to, getting a OT sat monitor at home or things like that, just to have so that they can help, monitor as well, at least in those first few rounds of treatment. And then, going through and actually getting the medicine. And then again, there's that transition point of kind of the handoff that's got to happen sometimes from this outpatient setting to an inpatient setting. Some of the drugs are a little harder to just do that way, and where you really just probably need to admit them for inpatient, the whole time. So, especially the ones where the step-up dosing so stacked, day 1, 3, 5, or things like that. So that's where we're doing that more, probably on an inpatient setting altogether. But a lot of the other ones, infused outpatient, then get admitted for observation. I think we've started to have some experience with the drugs, the bispecifics that can be done purely as an outpatient. And again, that's where having their caregiver being able to monitor them at home and let us know if there's anything changing or happening. So,
Do you feel like things have gotten easier as time goes on, or still like obstacles, or what's your kind of overall take?
Yeah, I think it's getting easier. I think, the reality is we give a lot of crazy treatments and, not just bispecifics, right? But from, when we first gave DARA, or we first gave, some of the immunotherapy drugs we might use for other cancers. And so I think we've gotten a little bit used to having to deal with the different types of toxicities and side effects. And so I think we've learned from some of those experiences. And as we get these things more operationalized, I think everybody's more comfortable with it. You've got nursing and pharmacy staff that's more comfortable with it. And so I think it's gotten better, and I think it will only continue to improve as we continue forward with getting more of these in clinic. And I think the other thing that's probably really taken bispecifics, off is the approval of, bispecific, like in the small cell lung cancer setting, right? So now you've got clinics really forced to figure out how to use these, because it's a population they're seeing and treating a little bit more commonly. So as far as a second line, treatment in that setting. So it's kind of push people to really figure out how do we give bispecifics and operationalize it better.
And speaking of which, you had mentioned, getting the pharmacists and nurses on board. And, this slide really kind of highlights the really multidisciplinary approach to operationalizing, the administration of these agents, getting the oncologists, of course, the advanced practice providers, nurses trained on patient education. They're going to be like sort of the first line of questions that patients, may ask. Pharmacists, of course, and social workers to help support psychosocial needs. And like when your practice first started actually administering these agents, either taking over for other, from step-up dosing administer at other places, or actually doing the step-up dosing yourself, did you have some type of meeting, or how did you operationalize this, where okay, we're going to do this, and then go from there, right?
Yeah. So we kind of did a few, I think there was some hodgepodge type things going on, but we sort of, as a physician group, came together. We had a couple of doctors kind of put together a sort of almost like a little mini PowerPoint for our group, where we could figure out how to operationalize it better. As I said, for the things inpatient wise, sort of picked initially one hospital and now a second where we're able to do these things. And then what I've found is actually fairly helpful is the companies themselves do have a really good education branch, right? Because they want their drug to succeed. So they actually do a really good job if you engage them, when you say, hey, we want to start this drug, of bringing in kind of education to the pharmacy staff, the nursing staff, and then they'll actually even come and educate the nursing staff on the inpatient side as well. So we've actually tended to do that for anytime we were starting maybe a new drug we hadn't used before, is have the company itself use those resources and kind of walk through those different people. And I think that was helpful just because it helps train and hear from the company who's got a little more experience with with how the operation works. And sometimes it's nice to hear from them just because they'd say, oh, well, this worked over here in Ohio or something like that. Maybe this could work here. And so it was just another way to get some ideas on how to operationalize it. So that's something we've tried to do anytime we have a new one of these bispecifics that we're starting to use. And then we've tried it's as some of these have gone more purely outpatient, is to see if we can be involved in some sort of the phase 2, phase 3 clinical trials to just be able to operate, figure out how to operationalize it in that setting. So
yeah, great. And then kind of last sort of slide on this kind of operationalizing this. So when you do step-up dosing, so you said that oftentimes you're doing step-up dosing perhaps at one of the local hospitals and have partners there that help sort of with that initial process. Is that correct?
Yeah, correct. Yeah. So I think, here we have kind of the relationship where we do have, privileges, and most of us do round at inpatient hospitals. And there's, I guess we're fortunate. We've got a couple of hospitals that are more of our bigger hospital systems where we're able to do things like inpatient chemotherapy, and they have much bigger ICU capabilities, those type of things. So at least at this point, what we've done is kind of a hub and spoke model of, let's do the step up dosing in those type of areas, and then once we get through that, we can hand it back off to some of our physicians that may be even further out, in suburban areas, or more rural areas. And so that's the way it's worked for us so far. I think initially most of these patients, they were treated at a large academic center, then eventually maybe came back and we gave them the infusions down the road that were after they went through step up dosing. But now we're sort of moving to at least trying to do this where we can do it in some of our bigger hospitals or bigger clinics where we have good hospital relationships.
And then managing inpatient versus outpatient transition. So like if a patient's hospitalized for the bispecifics, do you have a process sort of getting the patients, seamlessly, hopefully connected to the outpatient?
Yeah, I mean, I think that's been the tricky part, as we've talked about earlier. Is I think from just from a payer perspective, a lot of times we're having to give the infusion itself in the outpatient setting, then send patients over to the inpatient setting. We don't want that to be a far distance, so it's usually our clinics that are kind of located right next to the hospital. So they're going over there, and I think the big thing is communication with the hospital, making sure we have a inpatient bed that they can get monitored at. So that's always the one thing we worry about, is we want to make sure that we have a bed that's held for them. So it's just planning with the teams beforehand, I think. And then at this point, it's kind of been, we've got a core group of doctors who are there, to kind of on call for those patients so that we can deal with those toxicities if they're there. So really making sure that's there. We've certainly had our hiccups or things. One example was, got admitted to the hospital for observation, and one of the hospitalists was involved, but then kind of the messaging was mixed, right? And all of a sudden they're doing this crazy workup for fevers and all these other things where the patient was totally fine, but they kind of got mixed messaging on what was happening. And so they're okay, that can't happen. So it's re-educating and making sure things like that don't happen. Doing our best to, communicate between the different services, because outpatient to inpatient is always tricky, I think.
Yeah, and you talked a little about the reimbursement, co-managing patients, and how sometimes the drug's not reimbursed potentially when giving in the hospital. So hence you do it in the clinic instead. So, and just different strategies to work around that.
Yeah. No, I think that's been an interesting part, of how to to deal with these, because obviously a hospital doesn't want to just take on that big cost of these drugs if they're not going to get reimbursed properly for it. So so that's been something we've had to deal with the different patients and based on what payers they have and things like that. So how about in you guys' case, any issues with that? Or I'm sure there's been some, but
Yeah, and I think in part because the clinic and the hospital is one entity, so it's it's this one and the same. But I think for many practices, like you mentioned, the clinical practice is a different entity than the hospital, right? And they're two separate uh, uh, billing entities, and so I think that's where it becomes tricky, as you mentioned. I can imagine.
yeah. So I think that's just also involving your authorization teams and all that stuff, both the inpatient and outpatient ones, kind of early on to figure out what's going to work best for whatever situation people are in.
All right. So probably in the last 6 or 7 minutes or so, I did kind of want to highlight some of the management strategies for some of the toxicities that patients may experience with bispecific antibodies. So we talked about cytokine release syndrome, and this table really kind of goes over the grading system for CRS or cytokine release syndrome. So again, grade 1 is primarily just a fever. Grade 2 is when a patient is hypotensive requiring IV fluids or hypoxic requiring musical oxygen. And grade 3 and grade 4 are sort of escalating sort of supportive care requirements, either vasopressors or higher amounts of oxygen that the patient might need when experiencing these toxicities. And so there's been a lot of discussion about, how do we manage grade 1 CRS and what's the optimal way? And, certainly we can do supportive care, Tylenol or antipyretics, oral hydration, monitoring pulse ox, other vital signs, temperature, blood pressure at home. And then I think, there's been a lot of interest in doing all the step-up dosing outpatient, even in multiple myeloma. And there's been some strategies of actually prescribing a patient home dexamethasone to take. So if they get a fever, then they can take dexamethasone at home to mitigate the fever. And this is done often in lymphoma. So I think, that could be one strategy if a patient is getting outpatient step-up dosing to just self-administer dexamethasone and then, call their physician. If a patient is in the hospital getting step-up dosing, I think there's been a lot of interest in doing early tocilizumab to really decrease the duration of CRS to then move on to the next step-up dosing. And then certainly early tocilizumab would be indicated, if a trial dexamethasone doesn't work in quelling the grade 1 CRS. And then for grade 2 CRS, this really requires evaluation in person, and most often patient would need to be admitted for the management of the grade 2 CRS, particularly if they have prolonged hypoxia or hypotension. And so again, administering supportive care, antipyretics, tocilizumab would be indicated for any grade 2 CRS, or dexamethasone if tocilizumab doesn't have to be available. And certainly if a patient is refractory to tocilizumab, then that's when we would consider administering second-line corticosteroid therapy. And then grade 3 and grade 4 CRS, this requires additional higher levels of support care, often requires ICU transfers. Although I do want to highlight, just generally speaking, grade 3 and grade 4 CRS, while it's important to recognize when this would occur, is exceedingly rare, generally speaking, with bispecific. So again, majority of patients may experience grade 1 at the most, some grade 2, but rarely grade 3 and grade 4. And so again, there's been a lot of interest in trying to operationalize outpatient step-up dosing to really, limit hospitalization of patients getting these agents, but also improve access, so patients can get these agents wherever they are. And so one strategy is to administer potentially prophylactic tocilizumab before the initial step-up dosing of bispecific antibodies. So this is data from the University of Miami that was presented at the ASH meeting last December. And basically, you can see here on the far 3 right bars, elranatamab, teclistamab, talquetamab, the overall incidence of all grade CRS in the pivotal phase 2 registrational study. So all 3 FDA-approved bispecific antibodies targeting in multiple myeloma had over 50% all overall incidence of CRS. and some, had, over 75% like talquetamab. But when administering a single prophylactic dose of tocilizumab, the overall incidence of CRS dramatically went down to 14%, and there's only one grade 2 CRS event. And there was no additional tocilizumab or steroids given for CRS when utilizing this approach. So I think this is one really interesting way potentially to keep patients out of the hospital to really mitigate and decrease that risk of having CRS in general. And I think not only has this group looked at this, but several other groups have looked at this in administering myeloma T-cell antibodies. And it's ultimately, I think this data has really gained traction. Now it's actually on the NCCN guidelines as of April of 2025 to consider tocilizumab prophylactically before the initial step-up dosing for multiple myeloma bispecifics. This table really summarizes the management of neurologic toxicities or ICANS related to bispecific antibodies. Overall, this is fairly rare with bispecific antibodies in general. If it's going to occur, it's going to occur during the initial step-up dosing period. And really the initial management is dexamethasone and corticosteroids. So we typically don't administer tocilizumab for ICANS unless they have concurrent CRS. So dexamethasone or steroids is the first-line therapy for any ICANS. Rarely there can be higher grades of ICANS where we consider other drugs like anakinra or higher doses of steroids in that context. And then finally, I did want to mention sort of the long-term sort of infection prophylaxis strategies that are so important, particularly with bispecific T-cell antibody therapy. So if a patient can get vaccinated before receiving these drugs, that's nice because we know that once a patient do get these therapies, the vaccine response is significantly dampened. And so again, it's good to try to vaccinate before administering these therapies. We do generally recommend baseline viral serology testing. So if a patient has a history of hepatitis B, then we would recommend entecavir for prophylaxis to prevent hepatitis B reactivation. We do often check CMV levels at baseline as well. And if they have patients with asymptomatic viremia, that wouldn't necessarily be a contraindication to administer these agents. But if the level keeps going up, perhaps over 1,000, then we might consider preemptive therapy. And this is a bit of a gray area in the field, but something to be mindful of. And then for all patients, PGP prophylaxis and varicella zoster prophylaxis is mandatory. So it's really important to administer these prophylactic antibiotics to help mitigate, again, the risk of zoster or PJP. And then I think one real important area that has also emerged is the use of IVIG as primary prophylaxis to mitigate infection. And so there's really nice data shown by several groups that basically if you administer IVIG, again, as primary prophylaxis, the IgG level less than 400, even in the absence of infection, this can really mitigate the risk of infection for the long term, particularly in patients getting the BCMA-targeted bispecific antibodies. Really to wrap up, I think, we've talked on this program that, about some of the data that really supports the use of bispecific antibodies for both multiple myeloma and non-Hodgkin's lymphoma. And they've really emerged as an important therapeutic modality in an off-the-shelf format that can really be administered both in academic and community centers. And we heard from Dr. Yorio throughout the program of different ways and strategies that he's been doing it in his practice. I think what's really important is to really operationalize a plan to maximize the chances of success, to involve key stakeholders, pharmacists, nurses, patients, caregivers, again, to educate them on potential toxicities, where to go, if CRS would develop potentially, and then really kind of exploring different models for step-up dosing, outpatient versus inpatient, one site versus shared sites, and decide which model works best for the practice. And so I don't know, Jeff, do you have any closing thoughts, just from a community oncology standpoint of best tips or advice to administer these agents?
Yeah, no, I think it's, I think work with your clinic and work with the hospitals to try to figure out what's going to maximize your success, for sure. And then the IVIG is a great point because I think it's, shocking how much those drugs, the BCMA ones especially, just wipe out their immunoglobulins. So I think really trying to prevent infections is important as well with these medicines.
Great. Well, thanks so much. I'd like to thank everyone for tuning into this program, and really wish you all the success as you try these agents in your practice. I think these agents, again, bispecific antibodies, are here to stay, to form the backbone for not only relapse refractory multiple myeloma patients, but emerging data even for earlier relapse disease and even newly diagnosed patients down the road. And so want to thank Dr. Yoder for joining me on the program today, and thank you for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/PJA860.